In this video, we're going to do a comprehensive overview of the most important facts about all the most commonly used psychiatric drugs. Similar to the video on every major psychiatric diagnosis, I'm hoping that this will be a one-stop shop for anyone needing to quickly memorize psychopharmacology. We'll cover antidepressants, antipsychotics, mood stabilizers, anxiolytics, hypnotics, stimulants, anti-dementia drugs, and some that are used to treat various substance use disorders. We'll also include a few newer drugs that have come out since this channel launched over 10 years ago. First, let's cover antidepressants. The most commonly prescribed class of antidepressants is known as selective serotonin reuptake inhibitors, or SSRIs. There are a few main ones you need to know here. First is fluoxetine, or Prozac. Fluoxetine's defining trait is its long half-life, lasting 1 to 2 weeks. By focusing on the flu part of the name, you can remember that fluoxetine, like the flu, generally lasts about 1 to 2 weeks. Next, paroxetine or Paxil is the opposite of fluoxetine in that it has a short half-life. Remember this by thinking that a pair of oxen moves faster than a single ox. Next, sertraline or Zoloft has two key features to remember. While it can cause harsher gastrointestinal side effects like diarrhea and nausea, it is also one of the safer options in pregnancy and breastfeeding. Think of it as squirtraline to remember both the link to GI upset and the relationship to breastfeeding. Next, citalopram and its close cousin escitalopram are fairly middle-of-the-road SSRIs, but they can cause QTc prolongation on an electrocardiogram. Think of a car seat to remind you that electrocardiograms are required for citalopram and escitalopram. Finally, you have fluvoxamine or Luvox. At one point, it was the only SSRI that was specifically approved for OCD, but in reality, it's not really better for OCD than other SSRIs. Fluvoxamine does have lots of interactions with other drugs, often inhibiting the metabolism of both prescription drugs and recreational substances like caffeine. You can remember this by focusing on the love part of fluvoxamine to remember that it just loves being around other drugs, so much so that it tries to prevent them from leaving. Next are the serotonin norepinephrine reuptake inhibitors, or SNRIs. The involvement of norepinephrine leads to some additional clinical effects, including the potential for pain suppression, but also a risk of hypertension at higher doses. The balance between serotonin and norepinephrine is important as well, as we'll see. First, venlafaxine or Effexor is known for its short half-life, leading to severe discontinuation effects if stopped too quickly. The N in venlafaxine can remind you of the norepinephrine involvement. Like a fax machine, an old technology that somehow is still clinging on, venlafaxine can take a long time to taper off of. Venlafaxine also has a metabolite known as desvenlafaxine or Pristiq that is available as a medication as well. Next, duloxetine or Cymbalta has a dual mechanism impacting serotonin and norepinephrine about evenly. Use duloxetine to remember its dual mechanism and duloxetine to remember its capacity to dull chronic pain. Finally, we have Milnacipran or Savella and Levomilnacipran or Fetsima. These are more strongly noradrenergic than either venlafaxine or duloxetine, with Milnacipran having about equal effects on both, and Levomilnacipran actually boosting norepinephrine more than serotonin. You can remember this by thinking that milnacipran is in the middle of the scale, while levermilnacipran is like a lever that has been pulled to the opposite side compared to all the other SNRIs. Next, we have some atypical antidepressants with more complicated mechanisms. Bupropion or Wellbutrin is a norepinephrine dopamine reuptake inhibitor without significant serotonin involvement. This unique mechanism is good for a few things. First, you don't get the same sexual side effects you see with serotonergic drugs. It's also helpful for smoking cessation. You can remember this unique mechanism by thinking of it as a butane lighter, with DA and NE for dopamine and norepinephrine, and the fire reminding you of fewer sexual side effects in smoking cessation. Next, Mirtazapine or Remeron is an alpha-2 antagonist that has two defining traits. It is highly sedating and reliably increases appetite. Think of it as mealtazapine, with the meal for food and the Z's for sleep. Next, Trazodone is technically an antidepressant, but due to its heavily sedating effects, it's used more often as a sleep aid these days. One of the unique risks of Trazodone is priapism, or an erection lasting several hours, which can cause ischemia and is a medical emergency. Think of it as trazodone to remember both sedation and priapism. Vilazodone, or Vibrid, is both an SSRI and a partial serotonin agonist. So even though it appears to be boosting serotonin, it's actually not hitting the receptor with full force. It's a little lazy in that regard. Clinically, the lower serotonin involvement makes it have fewer sexual side effects than pure SSRIs. Think of it as Vilazodone to remember that it's a little lazier at the serotonin receptor than pure SSRIs. Finally, we have Vortioxetine or Trintellix. Vortioxetine seems to have some effect at boosting cognitive abilities, although it's worth pointing out that you can get the same effect by drinking a little bit of caffeine, the same amount in a cup of coffee or tea actually. An easy way to remember this is to think of it as Vortioxetine to associate it with that cup of tea. Next, we have an older class of antidepressants known as Tricyclic antidepressants or TCAs. These are pretty messy drugs with multiple interactions with neurotransmitters and ion channels, which makes them effective but also loaded with side effects. There are a few standouts to talk about here that you might encounter. First, Amitriptyline is one of the most common TCAs and has multiple indications beyond just depression, including chronic pain, insomnia, and migraines. You can think of it as any triptyline to remember that it can be used for just about anything. However, it is also strongly sedating and can cause orthostatic hypotension and even falls. If you're worried about those, especially for older patients, consider Nortriptyline, which is associated with less sedation and orthostatic hypotension. Remember this by thinking that elderly patients will fall less on no triptyline. Next is clomipramine, which is one of the most effective treatments for OCD. You can remember this by thinking that clomipramine is helpful for obsessive compulsive disorder. Next, imipramine has strong anticholinergic effects and has been used to treat bedwetting in children. Think of it as I'm peeing ramine. Finally, doxepin is highly sedating and is used as a treatment for insomnia at low doses. You can remember this by thinking of it as dozepin. Finally, we have the monoamine oxidase inhibitors, or MAOIs. These are rarely used these days due to their side effect profile, but you should know at least a few key facts here. First, there are two MAO subtypes. MAO-A is advanced and hits all three monoamines, serotonin, norepinephrine, and dopamine, while MAO-B is basic and hits dopamine only. Phenelzine, tranylcypramine, and isocarboxazid inhibit both MAO-A and MAO-B, while selegiline is selective for MAO-B. This makes selegiline also a treatment for Parkinson's disease, where you primarily want the dopamine and not the other neurotransmitters. And with that, we'll transition over to antipsychotics. Antipsychotics generally block dopamine receptors, although some of them include other neurotransmitters or modulate dopamine in other ways. Antipsychotics are often divided into an older class known as first-generation antipsychotics and a newer class known as second-generation antipsychotics. The first gen is not used very much these days, as the side effect profile is usually not preferred, but there are a couple that are still in use. First, haloperidol or Haldol is your prototypical first gen and is a very strong dopamine blocker. One key fact to remember here is that intravenous or IV haloperidol can prolong the QTC interval, leading to a potentially dangerous outcome known as torsade de pointe, which looks like twisting ivy on an EKG. Visualize the image of twisting ivy to remind you of this risk from IV haloperidol. The only other first gen we'll talk about is chlorpromazine or Thorazine, which is used these days primarily for its highly sedating properties. Think of it as snorpromazine. Next, we'll cover the second generation antipsychotics, which you can further subdivide into a few groups based on some key similarities. The first group is the apines, like olanzapine, quetiapine, and clozapine. These are not strong dopamine blockers, so they have less extrapyramidal side effects like stiffness and slow movement. However, on the flip side, they can cause sedation and metabolic side effects like weight gain. You can remember this by thinking of them as abenes, as eating a big bean burrito can make you sleepy and full. In contrast, the adones, like risperidone, ziprasidone, and lorazepam, are less likely to cause weight gain and sedation, but as strong dopamine blockers, they tend to have more motor effects like muscle stiffness. You can remember this by thinking of them as drones. Drones have to be lightweight enough to fly, but they are also quite stiff as they're made out of metal. Finally, there are the PRAs, like aripiprazole, brexpiprazole, and cariprazine, which all have PRA in their name. You can think of the PRA as standing for partial receptor agonist, as these all act as partial agonists at the dopamine receptor. Now, let's look at specific medications within each antipsychotic category, starting with the abenes. First, olanzapine or Zyprexa is one of the most weight-gaining. Focus on the O of olanzapine to think O for obesity. In contrast, quetiapine or Seroquel is not as weight-gaining but is highly sedating. Think quietapine for quiet time. Next, clozapine or Clozaril is the single most effective antipsychotic, but it carries a risk of potentially fatal agranulocytosis, requiring regular blood draws to monitor. Remember that you must watch clozapine closely. Finally, acenapine or sapphirus also interacts with serotonin and norepinephrine, leading to some efficacy in mood disorders, but also side effects like dizziness and orthostatic hypotension. Remember this by thinking of it as SNapine to remember serotonin and norepinephrine. Now let's look at the adrones. Risperidone or Risperdal has a high rate of hyperprolactinemia and gynecomastia. Remember that risperidone can give rise to a pair of breasts. Risperidone also has a metabolite known as paliperidone or Invega. This is basically identical to risperidone, so you can think of it as simply risperidone's pal. Next, ziprasidone or Geodon can cause QTC prolongation. Think of a zippy car to link it to an image of an electrocardiogram. Next, lurasidone or Latuda is helpful for bipolar depression. Think of it as low razidone to remember that it helps during the low phases of bipolar disorder. Finally, iloperidone or Fanapt is a mildly effective antipsychotic that can cause orthostatic hypotension. Think of it as high-low peridone to remember that when you stand up high, your blood pressure will drop down low. Finally, there are 3 PRAs to know. First, aripiprazole or Abilify is generally weight neutral and less sedating than other antipsychotics. It can also be used as an adjunctive treatment for major depressive disorder as well. Think of it as light and airy piprazole. Next, brexpiprazole or Rexulti is a partial agonist that blocks dopamine more than aripiprazole. You can remember this by thinking that brexpiprazole results in a heavier blockade than light and airy piprazole. Finally, cariprazine or Vraylar is another partial agonist that is unique in that it is helpful in both unipolar and bipolar depression. Think of it as cariprazine to remember that it helps to carry patients when they are feeling low from depression. Lastly, let's talk about a few medications that are used to manage some of the side effects of antipsychotics known as extrapyramidal symptoms or EPS. Anticholinergic drugs such as diphenhydramine or Benadryl and benztropine or Cogentin can work to rapidly improve a state of acute dystonia. Remember this by thinking that when a patient cannot bend due to acute dystonia, consider dibendhydramine or benztropine. There's also a newer class of medications known as vesicular monoamine transporter 2 or VMAT2 inhibitors that can treat tardive dyskinesia. There are 2 to know, valbenazine or Ingrezza and deutetrabenazine or Austedo. You can remember these by thinking that VMAT inhibitors are very much against TD. Alright, and with that we'll switch to talking about mood stabilizers, which are used to treat bipolar disorder. Mood stabilizers often have complex or unknown mechanisms of action, so we're focusing more on the side effects than mechanisms here. First, let's talk about lithium, which is helpful for both bipolar mania and, to a lesser extent, bipolar depression. Its side effects can be remembered by lithium SFX to remind you of its low therapeutic index with a high risk of toxicity, intestinal upset, teratogenicity, including a risk of Epstein's anomaly, hypothyroidism, interactions, particularly with other medications that are metabolized by the kidneys, such as NSAIDs or diuretics, urination, including polyuria, polydipsia, and a risk of nephrogenic diabetes insipidus, muscle weakness, skin changes like acne and hair loss, fatigue, and extra pounds. Next is valproate or Depakote. This is effective for mania only with no benefit in bipolar depression. Its side effects can be remembered using the valproic SFX acronym to remember vomiting, alopecia or hair loss, liver damage, pancreatitis, rebound seizures if stopped too quickly, ovarian cysts, interactions with other drugs that are metabolized by the liver, CBC abnormalities including agranulocytosis and low platelets, spina bifida in fetuses if taken during pregnancy, fatigue, and extra pounds. Next is carbamazepine or Tegretol, which, like valproate, is only for mania, not depression. It can also be used to treat trigeminal neuralgia and epilepsy. You can remember these 3 indications by thinking of it as CBZ: cranial nerve pain, bipolar mania, and seizures. One of its most notable side effects is Stevens-Johnson syndrome, a severe and potentially life-threatening rash that is more common in people taking this medication who are of Southeast Asian descent. Think of carbamazepine to remember the increased SJS risk in these patients. The final mood stabilizer we'll talk about is lamotrigine or Lamictal, which treats bipolar depression but not mania. Like carbamazepine, lamotrigine has a risk of rash and Stevens-Johnson syndrome. You can remember this by thinking of it as lamotrigine. Okay, we are now moving on to anxiolytics and hypnotics. We'll first talk about benzodiazepines, which are GABAergic drugs that act to quickly and dramatically reduce anxiety. Benzos can be recognized by the AZE in their name, like lorazepam, which is an AZE thing to remember. There are lots of benzos, so we'll look at just the most common ones. The main difference between them involves their half-life, as they can be split into short, medium, and long-lasting. You can remember these using the mnemonic phrase, Tom moved fast to lure the cat, but still took several dias. Tom being fast refers to the short-acting benzos, triazolam, oxazepam, and midazolam. Lure the cat refers to the intermediate-acting benzos, lorazepam, clonazepam, alprazolam, and temazepam. Finally, the word dias, which is Spanish for days, refers to the long-acting benzos with a half-life lasting several days, chlordiazepoxide and diazepam. There's another consideration with benzos, which is that they are often used for managing alcohol withdrawal, so you need to know which ones can be used more safely in patients with liver damage. You can remember these using the phrase outside the liver to remember oxazepam, temazepam, and lorazepam. There are a few other drugs that are used to manage various anxiety disorders. First, buspirone or Buspar is a serotonin partial agonist used for treatment of generalized anxiety disorder. If someone is worried about lots of things, including missing the bus departure, they can take buspirone, a serotonin partial agonist. Next, gabapentin or Neurontin is a calcium channel inhibitor that is used to treat various forms of pain, epileptic seizures, and off-label for anxiety. Use the pen in gabapentin to remember its uses: pain, epileptic seizures, and nervousness. Of note, a related drug known as pregabalin or Lyrica is similar to gabapentin in most ways but has a faster onset. Think of pregabalin as the leaner, faster version of gabapentin. Next, propranolol is a beta blocker that is sometimes used for pre-treatment of performance anxiety, like someone taking it before a speech or musical performance. It blocks both beta-1 and beta-2 receptors, so you can think of probanadol as something taken by pros to ban all beta receptors. Next, prazosin is an alpha-1 inhibitor used to reduce the severity of nightmares and PTSD. Consider writing the A as an alpha to remember that as an alpha inhibitor, then write in a few extra Z's so you remember to consider prazosin when your patients need to catch more Z's at night. Switching gears slightly, we'll talk about hypnotics, which are medications that help people to sleep. First, melatonin is a naturally occurring hormone that is released when the sun goes down to signal the brain to turn in for the night. You can think of it as melatonin. Next, there are a few antihistamines that are commonly used for sleep, as blocking histamine helps to induce a strong feeling of drowsiness. Diphenhydramine, or Benadryl, is an antihistamine with strong anticholinergic effects. You can remember its interaction with H1 receptor by writing it as diphenH1-dramine. Hydroxyzine, or Atarax, is another antihistamine that is selective for the H1 histamine receptor. It's sometimes used as an as-needed medication for anxiety. Write it as H1 drowsazine to remind you that it is selectively hitting the H1 receptor, and that makes somebody drowsy. There is a class of medications known as Z drugs, which interact with the GABA receptor to induce sleepiness. These differ primarily by half-life. Remember the order from shortest to longest by writing them in alphabetical order: Zaleplon or Sonata at 4 hours, Zolpidem or Ambien at 6 hours, and Zopiclone or Lunesta at 8 hours. Another hypnotic is suvorexant, which is an orexin receptor antagonist. You can remember this by thinking of it as soothorexant. Finally, there is sodium oxybate, which is not a traditional hypnotic, but is instead used in clinical settings to treat narcolepsy. By taking it before they get into bed, sodium oxybate can help to consolidate sleep at night and reduce daytime sleepiness for people who have narcolepsy. Alright, now we're going to go in a completely different direction and talk about stimulants, which are used to treat ADHD. There are two broad classes of stimulants: methylphenidates like Ritalin and amphetamines like Adderall. Methylphenidates are norepinephrine and dopamine reuptake inhibitors, which you can remember by putting the N and the DA into methylphenidate. In contrast, amphetamines are generally stronger and actually trigger the release of norepinephrine and dopamine into the synapse. Think amphetamines to amp people up. There are also a few non-stimulant options to treat ADHD that are generally less effective. You can remember these by thinking that atomoxetine, guanfacine, and clonidine are a good compromise. Atomoxetine or Strattera is a norepinephrine reuptake inhibitor that has a small effect size when used to treat ADHD. If you remember that an atom is a small particle in physics, you can remember that atomoxetine has a small part to play when treating ADHD. Clonidine and guanfacine are both alpha-2 agonists, which can lead to sedation and weight gain. Remember this by thinking that clonidine and guanfacine make you yawn and put weight on. Finally, while not technically a stimulant, it's worth mentioning modafinil, which works to keep people awake even if they've gone a long time without sleep. Remember this by thinking if you need mo time to study for definil, then take modafinil. Next, we'll talk about anti-dementia drugs, which are used to treat Alzheimer's disease and other forms of dementia. Most of these work by increasing the amount of acetylcholine in the synapse. In general, anti-dementia drugs are not very powerful and their effects tend to be transient. You can remember the drugs in this class by thinking of them as relatively good dementia meds: rivastigmine, galantamine, donepezil, and memantine. Rivastigmine has a short half-life. Think of a fast-flowing riverstigmine. In contrast, donepezil has a long half-life, allowing for once-daily dosing. Think one and donepezil. Galantamine is somewhere in the middle, with a medium half-life. Think of it like Goldilocks, right in the middle. Finally, memantine is an NMDA receptor antagonist that is used in moderate to severe stages of dementia. It helps you hold on to memories. Finally, we'll talk about some drugs that are used to treat various substance use disorders. First, there are two gold standard treatments for tobacco use disorder. Varenicline or Chantix is a nicotine receptor partial agonist, which you can remember by thinking that very nic clean is used to get very clean from nicotine. You can also treat tobacco use disorder by combining two forms of nicotine replacement, such as using both patches and gums. One form isn't enough, you need two. Think of it as a nicotine to remember two or more forms. Second, let's talk about the various treatments for alcohol use disorder. The gold standard is naltrexone, which is an opioid receptor antagonist. You can remember this use by thinking of it as someone who drinks no alcohol but still treks on. Disulfiram, or Antibuse, blocks the metabolism of alcohol out of the body, making someone feel horrible whenever they drink, including nausea, vomiting, and headaches. Someone on disulfiram wants to die whenever they drink alcohol. Acamprosate, or Camprol, is a modulator of GABA receptors that helps to stabilize a chronic state of alcohol withdrawal. You can remember that acamprosate is like a camping trip. It helps to relax someone who is far away from any source of alcohol. Lastly, let's look at medication treatments for opioid use disorder. There are two gold standards here. First, buprenorphine or Suboxone is an opioid partial agonist that strongly binds to the receptor and effectively knocks other opioids like morphine off it. You can remember this by thinking that buprenorphine boops the morphine off the receptor. Methadone is another treatment for opioid use disorder. It is a full opioid agonist, but due to its very long half-life, people are generally able to stay more functional while taking it. Like one and done Epizil, you can think of method one and done to remember its long half-life. Finally, there is naloxone, which is an opioid receptor antagonist that can help to reverse an opioid overdose. It is very fast-acting and can be life-saving in many cases. Think of it as nalbloxone to remember that it blocks the opioid receptor to prevent overdose. And that's it. If you have a solid grasp on what we've covered, you should be well prepared for psychopharmacology-related questions on exams and in clinical settings. Of course, there's so much more to these medications than just what was covered here. Want to know more about underlying mechanisms, drug interactions, or different formulations? All of that and more is in the Memorable Psychopharmacology book available on Amazon. Until next time, good luck studying.